Live.
Okay, thank you, Justin. Good morning. This is the Central District Board of Health meeting for Friday, April 16th, 2021. It is now 8:30 a.m. I am one of the two representatives from Elmore County presiding as chair. My name is Betty Ann Nettleton. I represent the county along with Representative Megan Blanksmore. At this point, I will call the meeting to order, and I will take roll call by county, starting with Ada County. Dr. Young.
Jane Young here.
Mr. Labrador.
Here.
Dr. Epperly.
Here.
Boise County. I know Ryan. Ryan?
Yep, I'm here.
Okay, all right, thank you. Elmore County? I don't see Megan on yet. Valley County?
Mr. Hasbrook here.
Okay, thank you, folks. Proceeding with our agenda, Director Duke, do we have any changes to our agenda?
Madam Chair, there are changes to the agenda today.
Okay, thank you. Okay, first under new business, we need a motion to approve our minutes from the March 19th, 2021 board meeting. Are there any corrections or additions to those minutes?
Madam Chair, I'll make that motion.
Okay, thank you, Alt. Thank you, Jane. We'll take a vote for approval by county, starting with Ada County. Jane Young.
Jane Young, aye.
Val Labrador.
Aye.
Ted Epperly.
Ted Epperly, aye.
Boise County, Ryan Sturm.
Ryan Sturm, aye.
Thank you. Elmore County. Megan Stilmata. And Valley County.
Mr. Hasbrook, aye.
Okay, thank you, folks. Those minutes do stand approved. Okay, moving on, we're going to hear from Laura McMahon, our Support Division Administrator, on our 2021 financial reports. Laurel, go ahead.
Good morning. Thank you, Madam Chair. We'll go ahead and get started with the budget report. Thank you, Dustin, for sharing the screen. So the first page is our budget to actual report, and as a reminder, this goes through the end of March, which is 75% of the way through the fiscal year. The trends that you see on this report continue to be similar to what we've seen all year, with the same impacts from COVID funding. However, this month's report, like last month's report, contains the changes that we made in the budget revision. So you'll see that most of the percentages are more on track than they were through January. The overall summary shows that our revenues are high at 89% of budget, which is ahead of where we would expect to be at 75% of the way through the year. And then our expenditures are right on track at 72% of budget. To go into a little bit more detail on the revenues, again, we're seeing similar numbers to what we saw from last month. We're ahead of our projected amounts at this point through the year. And some of the things where you see that we're at or above 100% at this point in the fiscal year, we don't anticipate getting any more funding in those areas through the remainder of the year. So they're showing that they're at the full budgeted amount or a little bit over. For our CDH, our contracts and fees are pretty close to our budgeted amount. For FCS, for Family and Clinic Services, also our fees and contracts are close to planned amount. And again, since the budget revision, the fees now show being on track with budget, as we've provided those less services that we've talked about throughout the year, such as dental care. Our other revenue is still high there, includes our home visitation funding, and then our total revenue in FCS is above target at 89%. And in expenditures, this is where you can see, again, the changes that we've made through the budget revision process. Everything is pretty close to on track, and overall we're at about 72%. We do still have some extra funding in the capital section there for funds that we've set aside for a project that's not yet completed. And we will talk more about that on the upcoming pages. And we can move to the second page of the report. And this is our standard comparison of the past 2 years. And again, we're seeing the same trends that we've seen throughout the rest of the year. Our CEH fees and contracts continue to be up higher than they would be at this point or have been at this point over the last couple of years. And our fees for Family and Clinic Services are down comparatively speaking. We do anticipate that for next fiscal year, our fees for FCS will resume to at least FY20 amounts, if not above. When we look at expenditures on this page, we can see that our personnel costs are very close to what was budgeted, just slightly over, and then our operating costs are under budget. And that's just a reminder of some of the lack of predictability and variation that we've seen this year with the different funding streams and funding patterns than what we would typically have. And we can move on to page 3. This is our March cash balance statement. And as a reminder, on this page, we received the second half of our state appropriation in January. So we did see in January that increase in the total cash balances. And then last month, we updated the reserve fund designations. So leaving the balances we see now, our cash balance less the reserve fund leaves a balance of $2.5 million in that undesignated cash balance. Okay, and then on page 4, we can go ahead and move to that. And this page has stayed the same for the last few months. No changes here, just including it to go into a little bit more detail on the project that we do have set aside. And again, just waiting until we have more space in the facility to be able to complete that very last phase of the remodel, including the new carpet, paint, and furniture. Okay, and we can go ahead and move into the COVID funding summary. And we are including this COVID funding summary as a standard.
Laurel,
Laura, can you hear me?
Yes.
Hey, this is Commissioner Hasbrook. You made the statement that you just got the second half of the state. So are we going to get some more from the state later on because you're not showing that in actual?
We got the second half of the state appropriation in January, so we're fully where we expect to be through this point of the fiscal year. We've received all of it.
So when do you receive the first half?
July.
Because if this new bill goes through, what we're hoping it does, the starting point is going to be March of next year. So we're going to miss out on that first half from the states. So we've got to figure out a way that we can pass that back on to the counties. Do you understand what I'm saying?
I do, Commissioner Hasbrook. And we have already anticipated what that might mean, what HB 316 would mean for us, and potential budgetary impacts. And we will have plans in place for whatever course and whatever date that might be effective. But yes, that would definitely change how that would flow.
Well, the thing that we got to get here pretty quick, because counties are starting to do budgets now, is they're going to need to know what that figure is going to be for next year for all 4 of us in this district. And I've seen some graphs from Seth at IAC, but I think we need to kind of nail those figures down a little bit so everybody can plan for their county budgets for that. It comes out of indigent, of course, but it would be nice if everybody knew going in here by end of August what that number is going to be.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, and I was going to talk about that during the budget discussion, but I'll just weigh in, is that the dollar amount that the counties will be expected to contribute in addition to the normal base county budget will be directly impacted based on the start date. So there's essentially 3 start dates being debated. January of House Bill 316, either January 1st, March 1st, or July 1st of 2022. If it were July 1st of 2022, the county funding would not be impacted for our fiscal year budget. Obviously, March would be about 25% of that fiscal year 2021 state appropriation, and then 50% if it starts January 1. So as Laurel mentioned, we have a plan in place for those 3 scenarios, and we should know by May 21st, at the time we have the budget hearing, where we're going to meet in this room on May 21st, what that exactly will look like. That assumes 316 has been completed. So we'll share that back out, but the budget I'm going to present to you will be based on 316 not passing. Basically, it's business as usual moving forward. We do have pretty good indication, which Commissioner Hasbrook will talk about under the Executive Council discussion, that it is going to pass. It's just that those dates are uncertain. And on a real positive note, from a financial impact perspective, with the County Medically Indigent Fund, all 4 of our counties would end up well in the black of not having to pay those claims and instead using those funds to pay the health district. So I'll stop there, and we can talk more about it when we get to the budget section. But that definitely, it's up in the air right now because 316 is still being debated.
Thank you, Laurel.
Okay, thank you. We'll proceed with the COVID funding summary. Okay, and this is a standard report that we'll include as long as it continues to provide value. So the comparison from last month to this month is that we've seen some change in the total expenditures and our remaining balances. As a reminder, these are all federal funds with the exception of that small Pacific Source grant. And then the CARES Act funding ended December 30th. The unused funds there were cleared out. Also to note, the bottom 3 grants that you see on this page are also used for public health preparedness operations and epi surveillance. So they're not all 100% for COVID. And our total expenditures are at about 3.9 million. Remaining balance as of 3/31 was 1.9 million. And you can see, if you look at last month compared to this month, the expenditures went up in both the ELC grant and vaccine planning, which is what we would expect. And then correspondingly, that's where our remaining balances went down, and most of the rest on this page stayed exactly the same. That is the high-level summary of this report, and I will stand for any questions.
Thank you, Laurel. The floor is open.
Yeah, Laurel, this is Ted Epperly. Just a question here. When I take a look at the funding sources, I still don't see anything on this particular list for the American Rescue Plan Act. Is that being, is that just being held separately, or is it just because we haven't received spending authority for it, or what is the status of that money coming to the Public Health Department?
Madam Chair?
Yes, go ahead.
Thank you, Dr. Epperly. Yes, we have heard that there is going to be about 16 million for the state from the American Rescue Plan Act, but we have not heard how it's going to filter down or how much is going to come to or through the public health districts. So it's a little bit of a holding pattern on that. There will be additional funding, but we are not sure how it will be distributed.
Okay, thank you, Laura.
Mm-hmm.
Madam Chair, this is El.
Yes, El, go ahead.
And kind of add on what Laura was talking about, they're telling us at the counties that there's a good possibility that the state is going to take those funds and put them in a trust until they decide how the counties can spend it. That's the latest we're hearing right now. The state gets money and the counties get money, but the state's saying that they may hang on to all of it and then work on it next year in the legislative session, figure out where they think the county should spend it. And I'm assuming that'll probably happen with the health districts as well. Laurel, my question to you is on the ELC grant, that 1.759 million. Do you think we're going to spend all that?
At this point, it's a little bit hard to tell how much we're going to spend. I don't have a strong feel whether we'll spend all of it or not at this point, but we'll continue to track it closely and let you know.
Is there an ending date when we have to send it back? Like the CARES Act, we had to send it back at the end of December, whatever we didn't spend.
I believe that one goes through September of 21, but I'm not sure. I can get back to you on that.
Thank you.
Mm-hmm.
Any further questions or discussion for Laurel? Okay, hearing none, we will move on to Natalie Bodine, who will give us a review of our vaccine status and distribution. So, good morning, Natalie, and the floor is yours.
Good morning, Madam Chair. Can you hear me okay?
Yes.
Okay, great. Good morning to the board. I'm going to give just a quick update on where Central District Health is falling within our vaccine planning and distribution. We'll look at our distribution timeline, allocation numbers, a quick update on the numbers that are coming in through the retail pharmacy program, an update on Johnson & Johnson and what we know so far, and then a final look at some health district and county level data from the Idaho Department of Health and Welfare data dashboard. The next slide, please. This is Idaho's vaccine distribution timeline, and this is showing just part of group 3. So wanted to just take a quick look at this. Last time we talked about group 3 opening up into age bands plus medical conditions and the different dates that the governor had put down as far as opening up eligibility. So CDH ended up opening up vaccine eligibility to anyone, no medical condition required, to 16 plus years of age and older on March 30th. So we actually opened up in our jurisdiction earlier than what the timeline had stated, which is something that the health district could do. So we did this and made this decision based on the increased supply of vaccine via our weekly allocation that was received for the Idaho Immunization Program, combined with vaccine that's being received in our jurisdiction through some of the federal sources like the Retail Pharmacy Partnership Program, the FQHC federal program, and other programs. So our vaccine supply has increased quite a bit. And then also having conversations and communication with our vaccinating providers across our jurisdiction about appointment availability and public demand. So considering all those things, we did decide to open up in our jurisdiction a little bit early. So we have been opened up to everybody 16 and plus for about 2 weeks now. Next slide, please. So again, this is a look at our weekly vaccine allocation numbers, and I had to split this into 2 slides now as we are looking into week 19. So this shows you our weekly allocation by type of vaccine, priority group that we are working through, and then total doses. And this slide shows you through about mid-February what we were receiving. Next slide, please. So this is where we are at kind of the last half of our vaccine allocation. So this takes us through week 19, which is starting on Monday. So you can see here that will be distributed to our vaccinating providers on Monday and Tuesday. We again received our 6 trays of Pfizer for a total of 7,020 doses. We went up just a little bit in our Moderna doses at 5,500. And then, of course, our Johnson & Johnson, which we'll briefly talk about here. With the pause, we did not receive any doses of Johnson & Johnson. And, of course, with our priority groups, all groups have been open 16 and plus for the last. I will say, and I was not able to update this slide as we were doing allocation yesterday, but there were some additional doses of vaccine that were made available to the districts and the providers if needed. And this came from other districts that were not able to allocate. They had leftover doses. So we were able to grab another tray of Pfizer. So we actually received 7 trays of Pfizer that we were able to allocate. So we took that additional tray and gave it to one of our major health that was able to manage that extra 1,170 doses. Next slide, please. So this is just a quick snapshot of our federal retail partnership program. I like to show this as this is a program that has really brought in a lot of vaccine into our jurisdiction, which has been a tremendous help in increasing those access points. This program was activated in Idaho the week of February 11th, so been running about 2 months now. And at this time, all pharmacies that were enrolled with the federal retail partnership program are now able to order and receive an allocation directly from this program. So that includes Walgreens, Rite Aid, Costco, Albertsons, Save-On Pharmacies, our Fred Meyer pharmacies, and then Cardinal Health, which in our area, I know that Red Rock is at Cardinal. So as of April 2nd, the total doses that have come into our into Central District Health jurisdiction is over 80,000 doses. So again, wanted to highlight that as this is on top of the allocation that Central District Health is receiving through the immunization program. So a good supply of vaccines has been coming into us. Next slide, please. So just a brief update, of course, this week, a lot of news on the Johnson & Johnson COVID vaccine. So on Tuesday, the CDC and FDA recommended pausing the administration of the Johnson & Johnson vaccine due to 6 cases of a rare type of blood clot disorder in the United States. And of those 6 reports in the United States, 1 person has passed away, another one is hospitalized, and all of the patients were women between 18 and 48 years of age, with symptoms occurring 6 to 13 days after vaccination. And none of these 6 cases were in Idaho. So in response to the CDC and FDA recommendation, Idaho Department of Health and Welfare did recommend to Idaho providers on Tuesday as well to temporarily pause administration. And then on Wednesday of this, the CDC convened a meeting of the Advisory Committee on Immunization Practices, or ACIP, to further review the cases and assess their potential significance. And on Wednesday, ACIP declined to change their current pause and cited the need for more evidence and that they did not have enough information at that time to make changes to the recommendation. So we are currently still pausing our Johnson & Johnson administration. How long that pause will be, we don't know, but we'll continue to update our providers as that information comes in. And then just for our health district to date, we have received 14,900 doses of Johnson & Johnson that have been allocated in our jurisdiction, and that's over the last several weeks. So we are going to be sitting on some inventory of Johnson & Johnson. This is held. Next slide, please. So the next slide pulled out some information off of Idaho Department of Health and Welfare vaccine data dashboard. This data is current through the end of Monday, or April 12th. And again, the data is pulled from IRIS, which is the state's immunization reminder information system. So this is a chart on the vaccination rates by health district. So you can see kind of in the middle of the slide there for Health District 4, PH4, we are sitting at 40% of 16 plus vaccinated. The dark green bar shows the percent fully vaccinated, which is 31% for Health District 4. And then the light green bar shows the percent of those that have received at least 1 dose in the 2-dose series. And that is sitting at 15% for Health District 4. So again, we are at 47% of our 16 plus vaccinated for our health jurisdiction. Next slide, please. So this is a different view, a little bit deeper dive, looking at distributed doses and doses administered for our health district. So we are at 82% for doses administered. So just over 300,000, 2,384 for distributed doses, and that does include first and second doses. And then doses administered is 248,037. And we are currently allocating to, it looks like approximately 38 or 40 provider locations. And again, this data does not determine vaccine availability. Some of the doses that may show as inventory either have been already scheduled, or maybe they're being held for a weekend clinic or a mass vaccination clinic. Or now in the case of Johnson & Johnson, that inventory will be held until that pause is and then again, providers have 72 hours to report data to IRIS after a dose has been given. So again, this data is current as of Monday. Next slide, please. So a final look, and this drills it down into vaccination rates by county. So, and this again is for 16 plus years of age. Data is current through Monday. Breaks it down, Ada County is sitting at 49% vaccinated, Boise County at 24%, Elmore County at 26%, and Valley County at 6%. The next slide, please. And this concludes my presentation. Again, I will make a plug for our call center, still operating Monday through Friday. So they're always to take calls from the public around vaccine, epi, any kind of investigation. So, and then a list of some additional resources. So I stand for any questions. Thank you.
Thank you, Natalie. The floor is open for questions for Natalie.
Natalie, this is Ted Epperly. Thank you for the report. Really appreciate the drill down because we asked you at the last meeting to do that. I want to make a comment about IRIS, and I want to ask the board's direction on what I'm going to ask. IRIS, as you know, is sadly under assault in the legislature. And I can tell you as a provider, I'm sure that Dr. Young can too, that we use the IRIS system all the time to help us continue to be aware of the vaccination status of our patients, not only with the COVID vaccine, but more importantly, with all the other vaccines that people get. We have all the time mothers that are coming in with their children. They can't remember exactly where they are in the vaccine series, and we query IRIS. We use it all the time to check on a person's tetanus status after they get a cut or a laceration and they can't remember how many years ago they had one. We use it all the time to be aware of how many Pneumovax shots an older person has had for pneumonia, or if they've received their 2 doses of the varicella vaccine to prevent shingles. I just want to make a point that the IRIS system is invaluable to us as a tool to help physicians and clinicians with their patients. I'm not aware of anything that transcends, the state having identified information on patients or the federal government having identified information on patients. That exists at a clinic level, not at a state or a federal level. Aggregate numbers are reported to state and the federal government. So with that said, I wonder if this board should write a letter to the legislature or to the Idaho Department of Health and Welfare advocating for the continued use of the IRIS system. I do not want to see this system stopped. It is a tool to be used positively to care for patients. And I'll stop with that and see if there are any further comments, but I would like to ask the board's guidance in a letter that we send to both the legislature, the governor, and the Idaho Department of Health and Welfare in support of IRIS.
Thank you, Dr. Epperly. Any further comments, discussion regarding IRIS?
This is Raul Labrador. I have not been following as closely as probably Dr. Epperly the debate, but I think before we write a letter, I think there should be a presentation on IRIS, maybe by the members of the legislature that are opposing it or may have some issues. I'm just not sure that they are completely opposing it. And then maybe some people who would defend it. I don't feel comfortable right now writing a letter without really understanding the 2 sides of the issue. And that would be my only point. I'm not agreeing or disagreeing with you, Dr. Epperly. I would just like to be better informed.
Okay, thank you. Any further
Betty
comments?
Ann,
Yes,
this is
go
Ted
ahead.
as a follow-up then.
Go ahead, Ted.
Raul, thank you. I respect that position. Maybe what we could do then at a subsequent meeting, and I'll leave this up to, again, the board's thoughts, but I think we need to make an informed decision on this in some fashion. And I agree, let's hear both sides of it. No problem with that, but timeliness is going to be important here. I would hate to see the IRIS system deep sixed somehow by the legislature. This is an incredibly valuable tool at a clinical level. So however we might affect that so that we can have the discussion.
Madam Chair, this is Raul Labrador again.
Yes, go ahead, Raul.
Just a quick question, maybe. Is there a bill right now before the legislature that is trying to get rid of IRIS, or is it just a discussion at this time?
I'm not absolutely sure, other than what I've read in the press, and it seemed like there was an effort to stop the IRIS system in the state of Idaho.
Okay.
And if anybody knows further, please add on now.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, I'm not aware of a specific bill. There was the concerns raised by the Republican Party leadership in the legislature, and it was specific to IRIS being used for adults. And as Dr. Epperly described, the system has been used for both children and adults for 2 decades now. And it used to be an opt-in system, and that was changed a number of years ago to become an opt-out system. So like here at Central District Health, we notify our child, the parents or guardians of children, or an adult when they receive a vaccine, that they have the opportunity to opt out of that system. We also would transfer the data if somebody receives an immunization, but it would be transferred to IRIS as an anonymous dose administered. That way it's documented for inventory purposes. So point being, there is a lot of concern that was brought up by, again, Republican Party leadership, and that is being handled between the Department of Health and Welfare and the Attorney General's office right now. What I've seen on it so far, as far as the follow-up, is that there are no issues as far as violating Idaho law, but as we know, if depending on the outcome of that discussion, there certainly could be bills brought forward. So I think it's worth informing the board. I'd be glad to coordinate a presentation, both by my staff, clinical staff. They're very familiar with it, but I think on a policy level, we have our own board member, Representative Langsma, who's the majority caucus chair, and I think she would help inform us on what is being planned. And unfortunately, she's not with us today, but we could do that on the 21st, or declare a special meeting if there was a bill introduced that was going to be intended to disrupt what we have in place, if that sounds okay with everyone.
Russ, that'd be perfectly acceptable to me. Thank you, Betty Ann. That would be fine. I think we just need to stay informed and abreast of something that is a public health tool that's used all the time and very positively to help us care for our patients. So that's why I'm speaking up now at this time. I just wanted to make one follow-on. In terms of the COVID vaccines, you talked about the 80,000 being given by retail pharmacies. One of the values of IRIS in a system where not only is it given at the provider's office, but by the retail pharmacy colleagues, without IRIS, we don't know what the status then of all of our patients are in terms of vaccination. So there's another example how in COVID-19 having the IRIS system so we can pull down data if a patient were to get it through a pharmacy, that becomes valuable. So for all those reasons, I cannot stand by and watch a dismantling of a 2-decade-old tool that is extremely helpful to the providers and patients in this state. And I'll stop with that.
Okay, thank you. Any further discussion regarding the IRIS issue? Hearing none, thank you, Russ, for taking that on, and we'll look forward to hearing more about that. Okay, proceeding on with our agenda, we will go to a review of our COVID-19 status by Kim Link, our communicable disease control person. Kim, the floor is yours. Welcome.
All right, thank you. Good morning, everyone. So I'm going to talk about what we're seeing right now, both locally and nationally in terms of COVID. Next slide. I want to start out with a quick overview of what we're seeing locally. So starting out with Ada County resident hospitalizations. This slide that I have here is similar to what I've shown in the past, but a little bit more simplified in that it is a single graph that shows both ICU and non-ICU admissions together, so total number of hospitalizations. And I'm showing for the year of 2021 only. So as we look at this, our numbers of people being hospitalized really has come down over the past few months from where we were over the fall and winter. However, what's been happening recently is that the number of hospitalizations has been inching up again. And unfortunately, this is happening in the face of having some pretty steady case numbers of COVID across Ada County. So in looking at this, it's a trend that is starting to concern me a bit. I think it's something that we need to keep an eye on. The thing that I am concerned about with this is that this might be an indicator of increased activity of the B117 variant in our area. That variant is one that I'll talk about in more detail here coming up. And it's one that we are seeing more frequently being reported. So when we're in the situation where our case numbers are staying the same, but our hospitalizations are increasing, that might be an indicator that the prevalence of the B117 in our area could be increasing. So again, something that we need to keep an eye on. Next slide. So looking at our case numbers, broke these up into a couple of different slides here. So we're going to start with Ada and Elmore counties. Ada is on the left-hand side, Elmore on the right. And for both of these counties, what we're seeing is over the past few weeks to a couple months here, we've been above 100 cases per 100,000 population. And again, I use that benchmark as an indicator of when we're seeing significant community spread. As I mentioned, for Ada County, our numbers have been pretty consistent. When we met last month, I know we had that jump in the number of cases per week going from about 300 to about 600. And at that point in time, we were definitely concerned that that might be the start of a new spike in illness. Thankfully, at this point, that hasn't panned out. We've stayed pretty consistent in the 600 cases a week range. Which is, it's good that we're staying consistent. However, the levels of community spread in Ada County are remaining high at this point. As we look at Elmore County, what we saw in the middle of March was a jump from about 20 cases per week to upwards of 40 to 50 cases a week. That number is continuing to be high. We're seeing that this is truly community spread. We aren't seeing that this is coming out of any specific clusters or outbreaks. So as far as Elmore County goes, that's an area that we do want to continue to keep an eye on, continue to look at messaging as far as public health prevention measures, vaccination, and testing as well. Next slide. So looking at Boise and Valley counties, what we're seeing here is that the number of cases have been at or below the 100 per 100,000 population. So these two counties are sitting in pretty good shape. I want to point out specifically as we look at Valley County on the right-hand side, you'll actually notice that graph stops at 328. And the reason for that is the week of 4/4, we actually did not have any COVID cases that were reported out of Valley County, which is a really nice thing to be able to report, and I hope that's something that we'll see more of moving forward. And as we look at our counties where we do have these lower number of cases, I think it's important that residents and the population, we're still aware that testing does need to continue. Even though case numbers are low, COVID is still out there and people are still getting sick from it. At this point in the year, it is definitely easy to attribute mild symptoms to things like spring colds and allergies. And I think it's just really important to continue to recognize that those mild symptoms, they might be spring colds and they might be allergies, but they might also be COVID as well. So I want to encourage people to still continue to get tested for COVID, still think about COVID, even though numbers are lower within some of our communities. Next slide. So switching over to looking at more of a national picture. Back in December, January timeframe, it was predicted that the B117 strain would be the predominant strain in the U.S. by March. And that is exactly what has happened. So as you look at this graph here, this is looking at the national picture of the different strains that are being detected across the U.S. B117 is the part of the graph that is in red. It's the bottom portion of the bar. And what you'll see as of March 27th is that right now over 40% of the virus that is being sequenced here in the U.S. is showing as that B117 strain. Additionally, if we look at the yellow or the middle portion of these bars, what you see is that the other variants of concern, so variants such as the California strains, the South African strain, the Brazil strain, all of those are increasing as well. So the end result of this is that the virus that we were dealing with a year ago, the common strains that we had been seeing circulating, those are becoming less and less common. And the viruses that are more transmissible and causing more severe illness are really becoming more dominant in our population. So in some ways, what we're seeing is the virus that we're dealing with now truly is different from the virus that we were dealing with a few months or a year ago. Next slide. So as we look at the impacts of B117, we've been seeing this play out in Britain and in Europe for a few months now as they're working through trying to contain surges of illness, looking at implementing public health prevention measures. And at this point, we're starting to see some of those impacts in the United States as well. And for anyone who wants to say that COVID is done, we're over, we've moved past it, unfortunately, they don't need to look any farther than what's going on in Michigan to see really what the impacts of COVID are currently. So I've pulled a few news headlines. These are ones that I pulled on Wednesday of this week, specifically looking at what's going on in Michigan. And unfortunately, what we're seeing are levels of illness and levels of hospitalization that are exceeding what they experienced back in the fall and winter. So in terms of the levels of hospitalizations that are occurring, they are higher than what occurred a number of months ago. And their hospitals are, again, grappling with the potential of being at or near capacity. They're looking at, considerations of crisis standards of care, of needing to delay care for people. Again, all of those things that we here in Idaho and across the U.S. that we had to deal with a number of months ago. The other thing that's occurring right now that we didn't see as much of over the fall and winter is that we're seeing more pediatric hospitalizations occur right now in Michigan. So they're hitting record highs of number of kids that are being hospitalized. And again, as we look at that B117 virus, it's a virus that's more transmissible across all age groups, and it causes more severe illness. So we've been lucky in the fact that kids have been mostly spared from severe illness up to this point, but now what we're seeing is that with this virus, this variant virus in particular, that it is hitting kids and that it is causing more severe illness for them. And that's, of course, very concerning as we move forward. And I think, as we look at this, it is easy to say, well, that's Michigan. We're not Michigan. But I think we have a number of things in common with what they're experiencing right now. in that the things that led to the spike happening there are that even though there are public health prevention measures in place and there are still people who are taking those measures, continuing to mask and social distance, and there are people who are getting vaccinated, unfortunately, they're dealing with a virus that is more transmissible, and really it's hitting a population where pandemic fatigue has set in. And that's squarely where we are right now as well, you know, recognizing that there is a definite interest in getting back to normal and being able to move past this. Unfortunately, as we're seeing with B117, that's not going to be the case necessarily, and we need to keep a close eye on what's going on across the U.S. and prepare for the potential of that to happen here. Next slide. So I want to talk a little bit about herd immunity, and this is a concept that we've talked about really since the beginning of the pandemic as far as what the goal is in terms of our prevention measures. And just to set the stage on defining what that is, the idea of herd immunity is that within a population, we have enough people who are immune to the virus that if somebody comes into that population and they're infectious, there aren't enough susceptible people for that infectious person to pass on the illness. We don't see transmission occurring. And it is something that, again, we've wanted to reach since day one of the pandemic and that we're still working toward. As we look at how do we get there and how much immunity is needed, that goal is not entirely known. It is dependent on the virus itself. So every disease, every communicable disease that we work with, different levels of population immunity are needed to be able to reach herd immunity. With COVID, being that this is a new virus to us, we've never reached herd immunity with it, so we don't know where that goal is. It's believed to be somewhere within the range possibly of 80 to 85% immunity. And I bring out that number, and again, as we talk about vaccines and where that magic number is in terms of the number of vaccines administered to reach herd immunity, one thing that we need to keep in mind is when we're looking at herd immunity, we need to look at the level of immunity among all the people who can get sick with COVID. So that's from, from birth up to age 100 plus. When we're looking at our vaccine, right now the vaccine that's on the market is for ages 16 plus. So we have this large group of our population, approximately 20% of our population, that is unable to get vaccinated right now. And that is going to be one of the most significant challenges for us in terms of reaching herd immunity. And as I mentioned, we have this goal percentage, but unfortunately it's not set in stone. So when we were looking at the old COVID, the variants that we were looking at last year, those were not as transmissible as what we're seeing now. So the level of immunity could have potentially been lower at that point, but now working with these more transmissible variants, we need to have more people immune to be able to stop the virus. Additionally, what we're seeing, especially with variants like the P1 variant that came out of Brazil, is this is a variant that's really good at causing reinfection. So people who've had COVID in the past are getting sick from this new variant as well, unfortunately. And that also means that we need to have higher levels of immunity in order to stomp out transmission within the population. And additionally, as we look at immunity, not all immunity is built the same. So we're seeing in our population that we're having immunity that's coming from natural infection and then immunity that's coming from the vaccine. And the immune response from natural infection really does vary from person to person. And what we see is that, by and large, people who have more severe illness tend to have a stronger immune response and a more robust immune response versus those who are having mild or asymptomatic illness. When we look at immunity that's coming from the vaccine, it's a more consistent and durable type of immunity. So all of those things are playing together to get us into the position of immunity across the population and moving toward herd immunity. Next slide. I thought it would be good to include an analogy as far as really what it is that we're trying to accomplish. So thinking about this in practical terms, right now what we have is we're trying to fill up essentially an immunity bathtub. Unfortunately, what's happening is that our bathtub is leaky. As we look at this picture that I have up here, you'll see our bathtub has two taps. The one on the right-hand side has smaller solid dots. Those are the immunity that's coming from natural infection. On the left-hand side, we have larger dots. Those are the ones that are coming from immunity from the vaccine. So if we were looking at this in an ideal situation, what would happen is that we have people who become ill, they resolve their illness, they become immune, and they have lifetime immunity. So they go into the bathtub and they stay there forever. On the same side, we have the vaccine. People would get vaccinated, they go into the bathtub, and this fills up over time and we would reach that herd immunity. Unfortunately, with COVID, that's not the situation that we're having. So what is happening is that we have those people who have natural immunity. They stay protected, they're in that bathtub for a period of time, but then what we see is that that natural immunity goes away. So those dots are leaking out. And as we look at vaccine immunity, we know that this vaccine is really, really good, but it's not perfect. So there are going to be some people who are vaccinated who never develop immunity. So again, those dots, a few of those dots leak out at the beginning, and then over time, this, what we believe is this vaccine is going to last a while, but most likely will need booster doses. So as people have that immunity wane, if they don't get booster doses of the vaccine, those are going to leak out as well. So the situation that we're in is that we are trying to fill up this immunity bathtub faster than what's leaking out of it. And as we look at this and as we look at what that means for herd immunity, you know, there is a potential that we might not reach herd immunity. This is a really high goal that we're trying to reach when we're looking at 80 to 85% of immunity within the population. And that's definitely led to some people saying, well, you know, if we can't reach the goal, then why are we even trying? Why are we putting all this effort into this in the first place? And the answer is that every step that we can make in that direction, the more that we can fill up that bathtub, the closer that we are going to come to being able to have a life that's more normal, that's back to the way that it was. So what we'll see is that there's going to be a level of immunity that we reach where we no longer have to worry about these massive levels of illness in our community that'll push our hospitals toward crisis standards of care. Once we have a little bit more immunity past that, we may find ourselves in the position where we can stop having these waves of illness. Beyond that, what we'll see is that we might reach a point where we stop having these large outbreaks of illness. And beyond that, we may be able to reach immunity that we still see COVID cases, but they're sporadic COVID cases. And maybe there are small clusters that are occurring, but that we don't see these wide-scale population effects happening to us. So every step that we can make to fill up this immunity bathtub is going to put us in a much better position than where we are today. And so it's something that we really do need to keep working toward. Next slide. So I want to take a minute to talk about COVID infection and what this looks like beyond the acute effects of hospitalizations and deaths. You know, we've been working with this pandemic and focusing a lot on the acute effects of the illness, just because that's been the immediate need. Just recognizing that we need to get illness levels down to keep our hospital capacity intact and minimize the number of deaths that are happening. But what we're finding as we move through this is that the effects of COVID infection go beyond the acute illness. Unfortunately, what we see is that many of these longer-term effects are not tied to older age. So we're seeing that younger adults can have long-term effects from COVID. And additionally, it's not tied to the severity of the acute illness. So what we see is that there are long-term effects among people who had mild illness, and there are long-term effects among people who had asymptomatic infection as well. And so as we continue to work through dealing with COVID in the long term, these are things that we need to consider, and these are going to be some of the public health goals, moving forward years into the future. So in terms of some of these long-term ramifications, one of the first ones, and one that is likely pretty well known to many people, is the idea of long COVID, or the long haulers. So these are people who 2, 4, 6, 8 months after their initial acute infection, they're still battling symptoms of COVID. A lot of times what these are things like prolonged shortness of breath, fatigue, headaches, and unfortunately they're severe enough symptoms that they're affecting a person's quality of life and affecting their ability to work and really be a productive member of society. The other thing that we're seeing is that this is a virus that's causing long-term, potentially lifelong damage to certain organs and organ systems. So we're seeing the idea of COVID causing heart attacks is something that's been really well known. We're seeing that there is heart, blood vessel, cardiac damage that's occurring that's even separate from that. So seeing that there is the potential for a person to have injury to their heart, and which can cause any number of different long-term effects. We're seeing that there's damage to lungs, which of course being a respiratory illness shouldn't come as a surprise. Unfortunately, what we're seeing is that this lung scarring, again, it's not necessarily the older adults or the people who had really severe illness. There have been some studies that have been published looking at college athletes, so the people who really are young, really healthy, and what they're seeing is evidence of lung scarring as a result of mild COVID illness. And it's not clear at this point whether or not that's going to go away, or if that's going to be something that these athletes and these other people who have it, that they need to deal with for the rest of their lifetime. Another area where we're seeing long-term effects is in the brain and neurologic systems. So we're seeing that people are experiencing long-term effects such as chronic headache and migraine symptoms. We're seeing that people are having long-term loss of taste and smell, issues such as ongoing vertigo, dizziness, feeling unsteady on their feet. Again, these are things that are going on that can be not only detrimental to a person's overall health, but their quality of life as well. And the reason that I bring this up is twofold. Number one, just to make sure that people are aware that COVID illness goes beyond what we see in that initial, 2-week period of a person having a respiratory illness, that these are some of the things that we're finding out, that this is a virus that is causing long-term health effects. The other reason that I bring it up has to do with vaccination. So as we look at vaccine being out in the community, there are a number of people who are concerned about the risks of vaccine, and that's making them potentially hesitant to go out and get vaccinated. And I think as we look at making that decision of getting vaccinated, having a good understanding of the risks is important. So when we look at the risks of vaccination, of course, anytime that a person is having something done medically, it's never going to be zero risk. There's always going to be some level of risk that goes on, whether it's a 1 in a million chance of something happening, 1 in 10 million chance. When we look at a lot of the illnesses that we vaccinate against, they're rare illnesses. So we look at a really low risk of something bad happening from a vaccine versus a really low risk of encountering the illness itself. When we're looking at COVID, that's a much different risk profile. So what we have is a really low risk of something happening from the vaccine versus a very real risk of not only being exposed to COVID, but becoming infected, a risk of having those acute illness issues, and also that risk of having long-term health effects as a result of infection. So as we weigh those risks, what we're looking at is the risk of something happening as a result of the vaccine versus something happening as a result of COVID. And I think that's a really important point to make, that we need to be looking at comparing apples to apples in terms of COVID risk. Next slide. So where does this leave us? You know, I think we're at a point right now where we're over a year into this pandemic, and I think more than anything, we've learned that COVID is much more complex than what we originally thought. We're recognizing that the disease process is more complex and the virus is more complex. This is something that we're going to have to continue to deal with in different ways over time. And unfortunately, it's true that we may not reach herd immunity, but every step that we make toward it is going to put us in a better position than where we are right now. And as we look at how we get there, the vaccine is the best way for us to be approaching that. And that's the end of my report. I'm happy to take questions.
Okay, thank you, Kim. The floor is open for questions for Kim.
Eddie Ann, this is Ted.
Yes, Ted, go ahead.
I'd like to make a comment. First of all, Kim, thank you. Great kind of in-depth look at not only where we stand, but some of the issues and challenges we face. The one thing that I would add, Kim, to your really good report is that one of the other major clusters of symptoms we're seeing on the long COVID are psychologic and psychiatric. Up to a third of patients can report post-COVID illnesses psychologically and psychiatrically, ranging from anxiety, depression, to actually much more severe forms of schizophrenia and psychosis. And so I just want to add that to the list of both heart and blood vessels, lung, brain, and neurologic, but also I think in the realm, and it could have been included in your list under brain and neurologic, but psychologic and psychiatric. The anxiety, depression, and symptoms like those that people have are very real and very debilitating for them. So I just wanted to add that to the group. This is a complicated illness, and nobody has a clue yet exactly how significant this may be and for what length of time. So thanks, Kim, for the report, and I just would add that.
Okay, thank you, Dr. Epperly. Any further questions or discussion points for Kim?
Madam Chair, this is Jane. I had a quick question.
Jane. Yes, go ahead.
Kim, that was fantastic. Absolutely awesome report. Thank you. I wondered if you know any more about the boosters that they're talking about. 6 months, 9 months, and for which one, or a year?
Madam Chair, Dr. Young, I think I'm keeping an eye on what's going on with that, and I think that information is changing on a nearly daily basis. I know I read this morning that FDA was recommending potentially a booster at 9 months, and I think that's something that we're going to have to continue to keep an eye on. The one thing that I would like to point out, and you know, as we look at the different variants that are circulating, there is always this question of, does the vaccine cover against this variant? And as we look at the idea of booster doses or reformulations, I think the thing that's most important to remember is that we don't get to choose what virus we are exposed to, and there are multiple viruses that are circulating. So the idea of getting vaccinated against what's circulating currently may help us down the road, and it's still going to be better than not being vaccinated at all.
Thank you. And I think therein lies the reason for the iris. Yeah.
Yes. Yes.
Thank you.
Betty Ann, this is Ted again. If I could just ask Kim one other question.
Yes, Ted, go ahead.
This concept of herd immunity, as you've said, Kim, is, it's out there, it's ethereal. We think it's 80 to 85%. Depends a lot on the infectivity of the virus and the like. And you're exactly right. We'll never get there until we get kids vaccinated, because we'll always be well below that amount. To that point, we know how what an issue this has become around vaccine hesitancy, vaccinations, school boards, vaccinations in schools. But from a public health perspective, I wonder, have we given thought to how we can collaborate with the school boards in regards to potential vaccination strategies once approved? And the Pfizer vaccine trials now, there are trials down to 6 months of age. There are trials in younger children that will probably be out, hopefully in the summer. But have we thought about partnering with school districts, school boards to at least start the discussion around how do we think about vaccinations, perhaps at the school level, maybe in schools, to try to maximize the numbers? Then I'll stop.
Madam Chair, Dr. Epperly, I know that those are conversations that are ongoing already. So, of course, we have the situation where students over the age of 16 currently can receive the Pfizer vaccine. Our work among our school task force is really focusing on making sure that the schools, the school board, school nurses have the information to provide to students as far as how to access that vaccine, knowing the benefits of vaccination. And I think as we see, hopefully we'll see that that vaccine will be available to our 12 to 15-year-old age group coming up next. I know we're seeing really good data about the effectiveness of the vaccine in that age group. And I would anticipate as we move through this, continuing to engage with schools and looking at how do we get that population vaccinated to the highest level that we can is going to be really important, because we know that having kids in school is a top priority for us to continue to move forward through this, but it needs to be done as safely as possible, and that includes vaccine.
Thanks, Kim.
Any further questions or discussion for Kim? Well, Kim, thank you for that very, very informative and thought-provoking presentation. We appreciate it greatly. Moving on with our agenda, we're going to hear from Elt, our trustee from the Executive Council meetings. Elt, go ahead.
Okay, just a couple of quick things, if I can find my notes here. House Bill 314, which is the one we've been working on, where the counties take over funding of the health districts, has been sent to the 14th Amendment, where it's they've tried to amend it, and so far they haven't really touched anything. The big issue right now is the start date, and we were kind of pushing for January 1. Senator Van Wood, Representative Van Wouden had really. They got with the hospitals, and the hospitals tried to get the start date in July. And Representative Vanderwood was really strong, really adamant about starting it sooner to help, fund some of the Medicaid costs that the state is incurring right now. So they kind of settled on March 1st, I believe. March 1st, yeah. And I have a really good feeling that that's going to come out okay. I think that's probably going to happen. We're going to have to do some interesting juggling of the budget when we get further on down the road to let, like I was talking earlier, to let counties know about what they're going to have to budget for this. But like Russ had mentioned earlier, All the counties, I think, are going to come out ahead on this. We're going to have a little bit left from in our indigent fund to cover our still local indigent things like cremations and rent and power assist, those kind of things that we deal with on a weekly basis. Just for example, last week in Valley County, we had 3 cremations. They're about $1,680 each that we still pay for. I know in the beginning, one of the big issues was the mental health holds, and we've been really strong to make sure that that's going to be a state function, that they're going to take that over, and that's still in the bill, so that looks really good. Just got to watch to see what the Senate does here next week. House Bill, I think it's 339, which was introduced yesterday in the House, was a bill that basically outlaw any kind of mask mandate by any government agency. It did pass the House, but I have a kind of a feeling that when that one hits the Senate, they're never even going to pull it out of the desk drawer. I don't think it's going to go anywhere. But I guess the part that's given me the heartburn on that one was our own Megan Blakesmith supported that and voted for it. And I can't wait to sit down and talk to her about it, because I don't know why she's on this board if she's not going to help us with public health. And that one was came out of the blue, went through really fast, and there's a lot of those that maybe the House will do, but at the Senate, those guys have a little more common sense, and a lot of that stuff is kind of stuck in a drawer and never brought up again. The other one that is a done deal that we kind of lost out on is House Bill 73. You guys remember I tried to push here a couple of years ago to where we could hire outside auditors to audit our books so that we could have those faster. Legislative Services is doing that, and they're still doing that, and they're going to keep doing it. And it's kind of a sad deal because we don't get those sometimes up to 2 years later. So they're really not much good. And then the other issue is they cost a little over $40,000 a year, where if we went with a private auditor, we could do that for half. But unfortunately, Mike Moyle was pretty strong about that, and so that one did get approved, and that's now law. So we're just going to have to live with it, I guess, for a while. That's really about all I have, unless you guys have something you want to ask questions on.
Okay, thank you, Elt. Floor is open for questions for Elt.
Elt, this is Jane. I've got a quick question.
Yes, Jane, go ahead.
With the House Bill 316, with all of the funding coming not through the state, how do you see that affecting our budget presentations to the counties?
Well, I was just sitting here earlier. In fact, I think we're going to go into that budget next for 2022, trying to figure out what each county is going to have to come up with. But you have to realize that you levy for public health districts, and then you have another levy for indigent. And what the state is going to let us do is use that indigent levy to supplement the health districts, to make up that difference. And, it's going to be probably roughly around 80% if they started in March, because the state will have to pay for the first 3 months of 2022. And then after that, the counties would have to kick in. It's kind of a cash flow challenge, Jane, because most of the counties pay usually in January and sometimes July after, tax drive. And so if it starts in March and we haven't got July taxes in yet, there's going to be some challenges there. The one issue that I think everybody needs to know, it happens all the time in counties, is that if we don't collect all the taxes, not all the districts get their full funds. So if we have people that don't pay their taxes, that you have up to 3 years, then we kind of cut back every district, including EMS or you name it. We cut back that percentage until we get those taxes paid in, and then you'll get those later on. It might be 2 years down the road before you'll get all your tax money from last year, so to speak. Does that make sense?
Yes,
And
thank you.
before we didn't have to worry about that too much. But I'm really excited to get rid of the indigent thing from the counties. It's a very expensive program. The CAP fund, which is kind of the state share of that, that's where they're hoping to pull in at least $20 million right off the bat to subsidize the cost for the Medicaid expansion, which I think is upwards, and maybe Ted knows this, around $80 million this year. And the state wasn't counting on that. So they came to the county and said, you can either lose your sales tax sharing revenue, or we can figure out another way for counties to pay for it. And that's when we approached them and said, you guys take over Indigent, we'll use that levy to make up the difference for the health districts. And I think it's going to work long term really pretty well. For one thing, we can do our own raises. We can pay our people whatever we want. We don't have to worry about that kind of stuff. We built all that into the bill as well. And so we're going to be a little more independent, which I'm looking forward to. And that's really all I got.
Madam Chair, this is Raul.
Yes, Raul.
Ted, I just have a question. I understand that Commissioner Rod from Ada County was opposed to it. Is that correct? And can you explain to me what his argument was, if that's correct?
Well, I can answer that if Ted can.
Yeah, Elt, I think he was referring that to you, not to me.
Okay.
All right, yes.
Basically, Raul, if you look on the next report, which is kind of the budget for 2022, it shows what each county contributes to Central District Health. And 80 counties is quite a bit of money, but it's all based on your valuation of your property and your population. And that's where Commissioner Beck had an issue, was he felt like that Ada County was having to pay more towards the health district than the other counties. But it's really the only fair way you can do it is based on population and your valuation. And that's what his concern. He felt like that the three smaller counties should kick in more.
Okay. Thank
Does that help?
Madam Chair, this is Jane. I had another question.
Oh, yes, Jane, go ahead.
Where's the rule that it takes 2 of the 3 counties to approve the budgets?
Well, I think that's already in code. All 4 of us vote on the budget every year. And,
right.
You know, we've all seen in the past where it might be 3-1, Boise Valley and Elmore County are yes, and Ada County's no. And so it's been that way for a long, long time. But Ada County has a lot more population and a lot more valuations to raise that levy from. And it's the way they set up the health districts in the beginning is each district has a major metropolitan area. And so that they can help kind of subsidize the rural counties to pay for the health district. It's always been that way. And I think it's a fair way to do it, personally.
So it's state code?
Madam Chair, this is Russ.
Russ, go ahead.
Yeah, Dr. Young, it's Idaho Code, Title 39, Chapter 4, and Section 424 is where what Commissioner Hasbrook described is already in code. Actually, to Commissioner Beck's concern, the revision proposed in House Bill 316 would actually allow the 4 counties in our health district to negotiate a different formula for the new money that would make up for the difference of the state general fund going away. So I did visit with Commissioner Beck, and I'm not real clear on what the concern is. That to me is an issue that's been in Idaho code for decades. And then the new money, again, if the counties wanted to, in our health district, it wouldn't have to be an Idaho code. They would just have to agree to an alternative formula, and the new proposed law allows them to do that.
Awesome. Thank you.
Okay, anything else for ELT? Well, hearing none, thank you so much, ELT. Well, a lot going on in the legislature for the health districts this year. Okay, we will go to turn the discussion over to Russ to talk about the proposed draft for fiscal year 2022. Go ahead, Russ.
Thank you, Madam Chair. So you have been provided with the fiscal year 22 proposed budget for Central District Health. Our fiscal year starts on July 1. And as far as the process goes, today I will present the budget to you and I will request your approval. The next step is I will go out and meet with each of the boards of commissioners, and you all have been invited to your respective county to participate if you're not already there, like Commissioner Sturm and Commissioner Hasbrook. That is just an informational presentation. And then on May 21st at 8:30, we will meet here as well as virtual. And that's when the chairs of each of the boards of county commissioners will vote on the budget. So that essentially is the final step. If for some reason the budget that you all approve today, again, either this budget or if you have modifications, we'll certainly do that. If on the 21st it was not approved, it must be approved per Idaho code before the first Monday in July, which happens to be July 5th, and the nationally recognized holiday for July 4th. So that's essentially the process that will occur between now and May 21st budget hearing. And I'll go into the budget now and answer any questions either as we go along or at the end of the presentation. We'll go to the first page. This is the summary of FTEs, expenditures, and revenues, and it looks far different than in previous years. Usually you could see consistency from year to year and some slight changes. This year, as we move into fiscal year 2022, we know we will continue to have a lot of funding available, federal funding coming through the state to assist with our response. So if you look at FTE line, for example, the FTE count is up considerably, up almost 25%, but that again is almost exclusively due to COVID response. Same with our expenditures. All of those areas are significantly impacted, especially the personnel budget, by COVID response. Then we have some one-time capital funding, which I'll review in a little bit more detail further into the document. Our revenue shows a 3% increase in county contribution, and that was based on the guidance that this board provided at the March meeting. What we have traditionally done is we've asked for a 3% increase from our counties during good financial years in terms of tax base and market value growth. And those of you who were on the board during the recession years, we did not ask for an increase. We kept level funding through that period of time. Essentially, I feel like that was being responsible, and the counties did not have the additional funding to contribute. So the 3% growth allows us to provide pay increases to our staff to try to keep up with market rates, which I'll talk about again here shortly. You'll note that the state general fund amount was increased by 2.9%. What that is based on is the governor's recommendation for funding the public health districts with state general fund. That almost certainly will change if House Bill 316 passes. Now, when I say almost certainly, if the implementation date of that bill were July 1 of 2022, then this number would be real close to what JFAC probably will appropriate. They usually go along with the governor's recommendation, but point being, there's some uncertainty here, and we will make the adjustments between now and May 21st to reflect the decision point made by the legislature on House Bill 316. So just to be clear, as far as what you're voting on today, that data point is definitely subject to change between now and May 21st. And of course, I will keep you informed of what that looks like and reissue the budget pages based on any adjustments we need to make. The total dollar amount should ultimately look the same. It will just be a portion of that will be shifted to the county portion of the budget. Then we have state general fund restricted funds. It shows a significant decline. This year we did not ask for funding for the Western Idaho Community Health Collaborative. The state was generous to provide us 2 years worth of funding, and now we're relying on grant funds as well as funding from our participating partners. That was the plan, and that is what we are executing. The $19,500 is for the citizen review panels for the oversight work we do for the foster care program, and that's more administrative on our part for that work. State Millennium Fund dollars, that's the tobacco settlement money. We plugged in a number that is exactly the same as last year. We don't know if that will change or not when we get our final state appropriation. Contract revenue is up significantly, again, primarily due to COVID, and our fee revenue is actually going up based on increasing patient volume in our family and clinic services division, as well as increasing demand in environmental health, particularly in land development. Then we have other revenue, interest revenue, and zero reserve funds. I'll just make a note on the reserve funds. We will look at what our available balance is at the end of the fiscal year, and per usual, we will bring reserve funding requests to the board at the August board meeting for your approval. Okay, so on to the next page. So what this shows, if you look at the box, if you approve and ultimately our budget committee approves a 3% increase from our counties for fiscal year 2022, on the right-hand side, the last 3 columns, you'll see what the increase, what that 3% looks like divided across the 4 counties based on Idaho Code 39424, market value, and population changes. So if that is approved, Ada County will see exactly a 3% increase, or $67,663. Boise County will actually see the largest percent increase, but the smallest contribution increase, $2,167. And then you have Elmore County at 2% and Valley County at 3.4%. Go on to the next page, please. So here you'll see the details at the top of the page, but I would call your attention to the bottom half of the page where you'll see, this will come as no surprise to anybody, Ada County's market value has increased by almost 10%, and the largest percent increase was Boise County. Their market values increased 20%, and that certainly would be what would cause their percent share to have increased more than any of the other counties. Now, the population data is interesting. It certainly went aligned with what we're seeing. The actual U.S. Census Bureau data is not going to be available till September, is what they're predicting. So per Idaho Code, the Idaho Department of Commerce is required to provide that. So they did provide us updated data for the population figures for the most recent year. And like I said, I know each year some of you will look at this data for your own respective county and wonder how could that possibly be accurate. But nonetheless, that's what we have. That's the certified data, so that's what we go with. And I'm sure it'll fluctuate, hopefully level out whatever the averages are over time that align with what's actually happening. I'm going to pause there before I go into the budget detail to see if there's any questions on the higher level numbers.
Thank you, Russ. Any questions for Russ?
Okay, we'll go on to the next page. So this is the revenue section of the budget. Again, we talked about the state appropriation. It's about a 2.9% increase compared to last year. We'll make the adjustments as needed based on the fate of House Bill 316. Contract revenue, you'll see an increase of 2.3 million. It's a 55.8% increase, primarily, but not exclusively COVID funding. If you look at the narrative there, we did receive a significant grant for the Valley County Opioid Response Project. It's about $1 million, and this would just be 1 year of that grant cycle. Clearly, the COVID response funding is the largest increase. And then due to increase in WIC participation and anticipated WIC participation, we should get another $200,000 of contract revenue. That money comes from the United States Department of Agriculture to the state of Idaho, and then it comes out to the public health districts for the administration part of the WIC program. We're the front line. We're the ones seeing the WIC families and allocating funding to them, as well as the education and breastfeeding promotions that we provided them. Next page, please. So in the fee revenue, it's about a 14% increase, or $237,000, as I noted. The significant increase is projected not in the actual fees themselves, but the volume of work that's being done that generates the fees for things like septic system permit issuance and oversight of that work, as well as an increase in family and clinic services programs. One thing I'll note here is that last year the state legislature had basically taken away some of the state general fund we were receiving for home visitation, and in place of that, Department of Health and Welfare has expanded Medicaid eligibility. So now, as we serve Medicaid families in the home visitation program, we can bill Medicaid, and we are generating revenue, and that will continue to grow. I think that was a great decision versus 100% state general fund paying for it. We're now allowed to take advantage of the federal match, and it will allow us to grow our programs and move further out into our rural communities. The other revenue section is again, increased Millennium Fund revenue from the projected fiscal year 21. Millennium Fund dollars were pretty, they weren't used as we had hoped, just because the in-person opportunities for tobacco cessation was severely compromised last year with COVID and the mitigation strategies that we have put in place. The reserve funding, as I noted, that will come up at the August board meeting, and then it also is discussed in February, depending on where we're at budget-wise. As you all know, at our February meeting, we made significant adjustments to our reserve funding because we had excess funds available because a lot of our employees had shifted their work focus from what they were doing and were billing the federal contracts for COVID. Now, that ended up being a good thing because it allowed us to move money into our operating reserve account and get closer to that 3-month target that the board has set for us as far as 3 months operating reserve. So the next page is the expenditure category. I'm going to primarily focus on this first section, the personnel costs. And again, based on the guidance that I requested and that you all approved, we are proposing to give our staff a 4% merit increase this year. So pending the approval of the budget committee on May 21st, we'll process that. I don't know if that will happen or not. Last year's pay increases that were approved both by the board and by the budget committee were essentially blocked by the state. That money is still in our budget, and it's my intent for those employees who were to get a raise last year and they're still with us, they'll get that delayed. And then this would apply to fiscal year 2022. So essentially, we do performance evaluations, and there's 4 levels of the performance evaluations. There's does not achieve, which very few employees end up in that category. And then we have achieves, solid, sustained, and exemplary. So with this structure, if it's approved, employees who receive and achieves will get about a 2% pay increase, solid, sustained 3%, and the highest level is 4%, although we're adding a little bit of a differential adjustment for those employees who've had consistently good performance, been with the agency for more than 5 years, and they're still below the policy level. So that's the only change, and that would apply across all 3 ratings. So I know that's kind of a big deal. You know, I think our staff are incredibly deserving after this past year. They kept all the other programs going, took on new roles, excessive work hours, mornings, evenings, weekends, throughout the duration of the pandemic. And we've certainly asked a lot of our staff. So I'm hopeful that you all will agree that that's appropriate. We'll approve it.
Russ, I want to interrupt you before you go on. I hope that's okay, but
Sure.
I want everybody to understand, and correct me if I'm wrong, but the raise that we authorized last year, they never got it yet.
That's correct.
So keep that in the back of your mind. We're already a year behind on any kind of salary increase, and we need to make sure we come through with that for those folks. And then the 4% on top this year, of course, is going to be more. My question to you, and I don't know how you figured it out, the 4%, you're saying it's going to be $638,000. I can't get that number. I can only get $445,000. And I took it 4%, both the salary and the benefits. You know where that $638,000 came from?
So what did you come up with? You said 640.
$445,236. If you take the full 11 million times 4%, that's what you get. So I'm not, what I'm wondering is if you didn't put this on the increase that you didn't get last year. Does that make sense?
Yeah, I would have to defer to Laurel or Michelle to respond to that.
Well, we need to look into that, make sure that number is correct.
Yeah. Okay. And we'll do that.
Okay.
And a lot of, there's some other, I guess the other component of that is there will be, and I'm just kind of guessing here, is we have a lot of staff who are temporary staff or limited service staff who will not be with us long term, and we're going to move them 2% also. So I'm thinking that might be the difference. So
your seasonal aren't in here.
Right, they would be, so we're gonna, that would account for the budget portion of it. The increase would be made up because that's, again, about 25% more staff. They're not part of the merit-based structure. We're gonna move them 2%, which is achieves performance. And the pay line, by the way, I haven't shared, is also moved 2%. So that's something that happened at the state. So there are employees who will fall below the pay line that will have to be moved to that pay line as well. But I'll provide more detail. I'll look into it, provide more detail. So the operating budget would be increased by about 12% compared to last year. A good chunk of that, as noted, is the Valley County Opioid Response Project. The majority of that funding is not going to our staff, but going out to the community and consultants and resources to help support the opioid situation and other drug use in Valley County. Next page is capital outlay. The main expenses there, you can see, is we're going to be purchasing 3 new vehicles to replace existing vehicles that have well over 100,000 miles, and that's kind of our target point when we try to replace them, to make sure we're not putting a bunch of money into maintenance, as well as potential safety risk for our staff that are spending a lot of time out on the road. In addition, we're buying a fourth vehicle because we're now sending an employee from Boise to Valley County to support the growth and the land development. So that's something that we needed for that employee as far as the travel to Valley County. Now we have a couple of miscellaneous facilities projects. I'm not going to go into the detail in the last 3 pages, but that pretty much describes program by program. We call them PCAs, and where the revenue is coming in, expenditures, as well as the district fund column, which is generally the state and county money that we receive and how that's being spent. So that is the end of my budget presentation. I'd be glad to answer any questions you have, and I certainly would request your approval for us to move forward with this and present this to the counties and ultimately for their approval on May 21st.
Thank you, Russ. The floor is open for questions or discussions regarding the proposed budget.
Russ, this is Jane. Will we know about the House Bill 316 before we do the presentations?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Well, I sure hope so, Dr. Young. It's been a long time. I thought it would be wrapped up sooner than this, and then they had to go on recess because of the COVID outbreak that they were experiencing. And yeah, Commissioner Hasbrook and I have been really watching that closely, and I don't have a guess. I would think in the next week or two they should have a decision made.
Well, the feeling in the legislature is if they don't pass it, they'll drop it and we'll end up where we are right now. So I think we're okay either way.
Okay.
Hopefully we'll know maybe by the end of next week.
Awesome.
Madam Chair?
Yes, Russ, go ahead.
Yeah, and to Elle's point, so this budget was based on 316 not passing. We base it on where we're at today. So this would be the budget that would be presented on the 21st. If 316 passes with an implementation date of either January 1 or March 1, that we're going to shift the state general fund dollars over to the county share.
Awesome. Thank you.
Okay, thank you, Jane. Thank you, Russ.
Madam
Chair, this is Raul.
Yes, Raul, go ahead.
Russ, I just have a question. Can you please explain again what you said about the employees? I understand the 2, 3, 4, but what's the additional money that you're saying is going to be paid also in bonuses?
Madam Chair?
Yes, go ahead, Russ.
Yeah, so there will be no bonuses. What we are planning to do so the matrix, the structure I described, the merit-based increase would be based on all of our existing staff, permanent staff, probably around 123, 125 staff. There'll be an additional 2% increase going to all of our COVID response staff that are temporary staff. That money is reflected in our budget, but 100% of that is coming through the federal COVID funding.
Okay. Madam Chair, follow up?
Yes, go ahead, Raul.
And Russ, maybe I misunderstood or misheard, but you mentioned something about the staff did not receive something last year and that they were going to be made whole for that. And I just want to understand that because I'm not sure I heard it correctly.
Madam Chair?
Yes, go ahead, Russ.
Yeah, and I appreciate you asking that question. So this board and me, I'm actually given the authority to set the rate of pay for our staff in collaboration with the board, and the board either approves it or they don't. Clearly, we're not going to move forward with something that the board hasn't approved. Last year, we built a pay increase. It was a 3% merit-based pay increase into our budget. This board approved that. Our counties approved it, so the money's in our budget, and it did not get implemented because of this current circumstances with the state oversight, which we know or I guess we believe they don't have the authority to do that. Nonetheless, that's something that they exercise. We have an AG opinion on this that Chairman Nettleton had requested, stating the same. So those funds are there, and it's my intent for any employees who are still, and again, I shouldn't say any, a lot of our employees are still here who were due that pay increase last year that they would have seen in July. We're not planning to do that retroactively. We're planning to include that in addition to this year's merit-based increase based on the budget for fiscal year 2022.
Okay, thank you.
Sure.
Rel, this is El, or Madam Chair, this is El.
Yes, El, go ahead.
Rel, I think it's really important to realize that if this new bill doesn't go through, we would still lose that ability to give pay raises. That's still determined by the state, and the state held it up last time. My question to Russ would be, if we've already funded that raise and the money's sitting there, can we go back retroactive?
Madam Chair.
Yes, Russ, go ahead.
So per the state's rules, or DHR's rules, Division of Human Resources, that would not be allowed. If 316 passes, it'll be a different circumstance. But you're right. I mean, it was funded. It was blocked, not by this board or by our counties, but by an authority that we believe is by an entity that we do. We have an AG's opinion saying that they don't have the authority to do it. Nonetheless, all of our raises are processed through the state of Idaho. We use the state controller's office, and until the Division of Financial Management, DHR, approved them historically, they basically just sit. One other thing I wanted to point out that I think is really important for this discussion is that Central District Health clearly very much aligns far more closely with our counties than we do with the state. Our relationship with the state is we get a state appropriation, and the amount roughly the same as our counties, and we have a lot of contract funding coming in. This board is appointed by our counties, so the governing body is really directly connected to our boards of county commissioners. And secondly, it's not the state that approves our budget, it's the counties that approves our budgets. So what I do every year, our HR staff reaches out to our counties and they identify what their pay increases are. So I have the history on that. I don't have it here with me today, but I will share that actually with you via email so you can see that. Typically when we're in person, I've shared it, but I just didn't get that done for this particular meeting. But what I want to tell you is that we have always tried to be, I feel like, being responsible. We would not want to get way out ahead of our counties, like giving larger increases than our counties are. But where we're at today is we're quite a bit behind. If you look at the last 10-year period, 2 of our counties were very much in line with Ada County, almost exactly what they've done over the last 10 years, and we're a bit ahead of Boise County. But Boise County, we're missing 3 years of data that we're still trying to get. But just in general, I will tell you, I feel really comfortable with what we're proposing to do. That our increases historically and as being proposed very much aligns with our counties and what they're doing for their own staff.
Okay, thank you, Russ. Any further questions or discussions for Russ before we, this is an action item. So we
Betty Ann, this is Ted.
Yes, Ted, go ahead.
If the board's ready for a motion, I'm prepared to make one.
Okay, well, hearing no further discussion, proceed, please.
Okay. I'd like to just say that the Central District Health Department performed marvelously through this last pandemic. This was an unbelievably challenging period of time, and CDH went above and beyond to make all the public health provisions that were done work, and showed incredible fortitude and collaboration, I think, in doing that. And to the personnel issues, I would just say that our people are our most important resource. And I think we must ensure that we are paying appropriately to keep talented people, or we start to lose them to other efforts. So with that all in mind, I would propose approving this budget as presented by Director Duke, as noted, and that would be my motion.
Madam Chair, this is Al. I'll second.
Okay, thank you, Dr. Epperly. Thank you, Els. Any further discussion before we call for a vote for the proposed budget? Okay, hearing none, I will ask for a vote by county, starting with Dr. Young.
Jane Young, aye.
Dr. Epperly.
Ted Epperly, aye.
Raul Labrador. Boise County. I'm sorry, did Raul, are you there?
Yes, I am.
Okay, what did you vote on that?
Aye.
Aye, okay. All right, Boise County.
Commissioner Sturm, aye.
Elmore County. Megan is not there. Valley County.
Commissioner Hasbrook, aye.
Okay, thank you, folks. That motion does pass. At this time, I am going to call for a 15-minute break, so we will reconvene at 10:35 for the remainder of our agenda. Thank you.
Get Laurel. I don't know.
All right, we're coming back live here now.
Okay, thank you, Dustin. Okay, this is the Central District Board of Health reconvening our agenda. And at this point, we will move forward with Director Duke's district report.
Thank you, Madam Chair.
Mm-hmm.
I will start with IAB 2021. So that is being hosted by the South Central Health District, which is Public Health District 5. And it's going to be on Thursday, June 17th. And I know Donna has communicated with you about that. They are still up in the air whether they want to offer an in-person option as well as virtual. It's kind of gone back and forth as far as communication I've seen. I don't think their board has made a decision. For sure, it will be available virtual. It will only be the business meeting, which generally takes about 2 hours. So my thought is, if, depending on where you're driving from, that's a pretty big trip for a 1 to 2 hour meeting. They're also not sure if they're going to do it in the morning or afternoon. So I'm sorry I don't have detail on that for you yet, but as soon as we get that confirmed, I'll send that out to you. Obviously, we know the date. That's it for right now. So for next year's Idaho Association of Local Boards of Health, Public Health District 4 is the host. So I'm just kind of planting the seed right now because by May 21st, which is the budget hearing that I talked about, the board meeting follows immediately following the conclusion of the budget hearing on May 21. Then I would like to get your guidance on, maybe you have it now, as far as where you would like us to start looking for a place, and then maybe the dates. We always try to avoid Memorial Day weekend, either that Thursday or Friday leading up to it, or Thursday or Friday following Memorial Day, just because of holiday travel. So I guess the first question is, where would you like to hold that meeting? I've been here for 2 Central District Health hosted meetings. The first one we did in Boise, and the second one we did in McCall at the Shore Lodge. So if you guys have some suggestions now, I'll take them. If you would like to think about it, that's fine. But the critical point of May 21st is it'd be whatever you decide, then we would announce it at the June 17th IAB meeting hosted by District 5. So I have some more items I wanted to cover, but I don't know, Madam Chair, if you guys want to have a conversation about that. I did send an email to you, so you'd have a heads up before today. I'd like to hear your thoughts if you have any.
Any thoughts from the board regarding that IAB meeting in District 4?
Madam Chair, this is El. Just so everybody knows,
go ahead.
June 19th is Father's Day, which is a Sunday. Maybe the week before, the 15th, 16th, 17th, something like that would work. Just an idea of just.
That sounds great.
Works for me.
I was thinking the 17th, which is a Friday.
Perfect.
Mm-hmm.
And I think we should all go to Jane's house and have a big barbecue.
That'd be fun. I'd love it. Well, I was going to say someplace in Mountain Home because we haven't been there yet, and it'd be nice to have them feel the support.
Well, actually, we did have it in Mountain Home. Gosh, what was it? 4 years ago? 5 years ago?
When we went to Glen Springs in 8.
We went to the Three Island Visitor Center.
Right.
Yeah, that's right.
Madam,
We could do it at the Brunel Sand Dunes.
There you go. There you go.
So,
Hey, let me
No,
tell you,
outside, it's socially distanced.
Bruno Sand Dunes can be mighty hot that time in June.
Yeah.
Mhm.
So does the board just kind of want to think about that until our May meeting, and we'll have some ideas pulled together?
That'd be great.
Does that sound okay, Russ?
Yeah, it does, Madam Chair. And we're just looking for, like I said, if you have some dates narrowed down, like what you talked about. Then the main thing I need to know is the preference for location, and then we'll start working on getting things booked. It's good to do it a year in advance, just so we can get the better prices and the locations, especially if we're going to some of our rural counties. There's not a lot of options. And reminder, this is for the IAB meeting, probably with directors and board members who attend, it's roughly around 45 or 50 people total. So anyway, thank you. And I'll look forward to guidance. And if you have thoughts you want to share between now and the 21st, just send it to all of us. You know, again, it's not a decision. It'll just be you making suggestions for things that we might want to consider so we can get this nailed down on the 21st. I was going to also mention that at our May 21 board meeting, that's at the point in time where we'll set our fees. So we're going to bring a fee schedule to you for both all of our clinical services and all of our environmental health services. And we'll get those out to you ahead of time. We always, compare those to last year, and any changes, we'll explain those to you. The last thing I was going to mention that is of significance is we have a public health advisory that's currently in place, and we issued this on February 19th, and that was based on what we were seeing at the time with social gathering exposure, workplace exposure. So we were, I would say, pretty descriptive and prescriptive in what we were expecting from our communities. And within that, we put a duration of advisory so that you all would know, as well as the public, when we would modify that advisory. Not an order, but a strong recommendation. And there was two primary factors. One of them was based on data. So when the 2-week average daily case rate remains less than 30 cases per 100,000 population, that's one factor, and we are there. We've been below that for quite a few weeks now, for the matter of fact. And then the second variable was that our 65-plus-year-old population had the opportunity to be fully vaccinated, and fully vaccinated, kind of the longest time frame for that would be for the Moderna vaccine, which is 28 days apart plus 2 weeks. As you recall, that started on February 1st is when it became available. So we're looking at when did the interest drop off from the 65-plus-year-olds. It was around March 5th, and that's when we opened it up to the next group, just because providers throughout our 4 counties were not filling appointments. We're going to give another 1-week buffer after that. That would mean people would be getting their first doses around March 11th, March 12th. And that's, again, worst case scenario. Most would have already received it by then. Plus 28 days, plus 2 weeks. Where we end up is approximately April 24th. So that day is coming right up. So it's our intent, assuming everything stays stable with the number of cases getting reported, we will be modifying this advisory to be effective on Saturday, April 24th. I have no intentions of lifting it. Again, it's not an order. I think it's our responsibility to keep providing guidance to our communities, to our businesses, on what they can do to take steps to protect our community, and certainly to prevent what we see happening in places like Michigan. So it will be definitely, I would call it, softened a bit from where it is today. And I'll share that out with you before we we issue that, but it does come from our staff. Wanted to give you a heads up. Again, it's a decision point that we've met our metrics. We can always go back the other direction if things go south, as they say, but that's the plan. So that is all I have, Madam Chair, and I'll be glad to answer questions.
Okay, thank you, Russ. Did I hear somebody speak?
Yeah, Betty Ann, I have a question. Russ,
yes.
yeah, thank you. I must have missed it. What is it exactly you're going to soften for the advisory?
Madam Chair?
Yes, go ahead, Russ.
So we had language in there, Dr. Epperly, where, for example, in our current advisory, avoid social gatherings, including among family members who do not live in your household. Well, today, CDC's changed the guidance on that, obviously, with a lot more people being vaccinated. You can have families getting together. You can have social gatherings, and of course, mask or no mask, depending on vaccination status and things like that. So that just being an example of something that we would not want to continue ongoing. It doesn't make sense today compared to where we were back in February when we were just getting vaccinations really ramped up, especially among the high-risk group.
Madam Chair,
Russ,
Yes, Al, go ahead.
If I could just follow on first, if you don't mind.
Sure.
Oh, sure.
Thanks, El. Thanks, Betty Ann. Russ, I understand the intent. Are you talking about softening beyond what the CDC guidelines are in terms of social groups?
Madam Chair?
Yes, go ahead, Russ.
No, when I say no, what I don't want to do is, if we were to base our advisory on CDC's current guidance, I'm sure you've probably seen it. They have the pictures and the diagrams and the grandkids and the grandparents, who's vaccinated and who's not. I don't want to get into that. That's something that we'd always be playing catch up on. So, we haven't exactly nailed it down yet as far as what we're going to provide, but it would probably look more like suggesting following the Centers for Disease Control and Prevention's guidance. I think that would be appropriate. That way we don't have to adjust it, but make that reference. But certainly masking is, in my opinion, is going to be appropriate to wear a mask in public places, indoors, where you're around others that you have no idea what their vaccination status is. Grocery store, for example. I think it would not be responsible to suggest you can go into a grocery store after April 24th without a face covering on. But I don't want to, like I said, I'm trying to figure out, we're working with our team, of course, Kimberly Link, as you all know, she's an expert on this, is what would it look like that we could do something that's kind of durable into the future, reference for disease control, which we've always done. And they certainly are the public health experts for the United States, and allow this to kind of move forward with the plan to make adjustments if we take a turn for the worst.
Okay, thank you. That helps clarify it. Appreciate it.
Sure. Madam Chair, I wanted to, I know Natalie covered this, but I was just going to let you know, when you look at the dashboard, our district's going pretty good, right, with vaccinations compared to the rest of the state. But our 65 plus year olds, when we talk about herd immunity and debate all that, for the 65 plus year olds in our health district, it's just shy of 80% have received one dose, and 73.3% have received the complete series. And so clearly there's a little bit of a gap there that's we think will get caught up. The 65 plus year olds are currently still getting second doses, depending on whether you got Pfizer or Moderna. Obviously, if you got the Janssen vaccine, that wouldn't be needed. But I personally, I'm really, really pleased to see that we have 80% of the high-risk group vaccinated. I think that's a big deal, and hopefully others will get it later on, and they've changed their mind if they're still on the fence about it.
Madam Chair, this is El.
Yes, El, go ahead.
Just a couple of quick questions for Russ. No, I understand Boise City and McCall still have a mask mandate on. This won't affect any of that.
Madam Chair,
Go ahead, Russ.
Commissioner Hasbrook, it will not. So our advisory is just an advisory. It doesn't supersede any orders that might be in place from, the federal government regarding public transportation or local orders, as you mentioned, with the city of Boise or the city of McCall. They'll remain in place and they manage that however they choose. That's all I have, Madam Chair.
Okay, anybody have anything else for Russ before we move on? Okay, hearing none, we will move on with our agenda. And as chair, I will announce that we will be moving in to an executive session in accordance with Idaho Code 74-206 at this time. I will take roll call according to counties, starting with Ada County.
Jane
Dr.
Young,
Young.
aye.
Raul Labrador.
Aye.
Dr. Epperly.
Ted Epperly, aye.
Commissioner Sturm, Boise County.
Commissioner Sturm, aye.
Thank you, Ryan. Elmore County, Representative Mike Smoth. Valley County, Commissioner Hasbrook.
Mr. Hasbrook, aye.
Okay, thank you. Dustin, will you let me know when the public will fall off of the meeting? Are we already?
Madam Chair, this is Russ. Let me, I know it's a little bit of a
Let's back
challenge.
up. Let's back this car up.
Yeah, let me, yeah, Matt, if you could get, it's Christina. What's that? Probably in her office. Maybe Ed could help you as well. He just logged by. Oh, Christine's here. And then Dustin can bring us back on live.
We're back.
Oh, okay.
All right.
All right.
Good to go.
Do you want me
Thank
to go
you.
ahead and repeat that motion to come out?
Yes,
No.
please.
Deb can make
No,
a
you
motion.
don't. You don't have
Okay.
to make a motion to come out, Betty.
Yeah.
You just,
I
yeah.
was a little bit confused whether we were live or not there. So, okay. All right. I think that everybody's clear on that issue right now, so we will take that up again on our May 21st meeting, and a lot of that depends upon whether a 316 passes or not. So, is there anything else we need to discuss before adjourning our meeting today?
We need to have a motion.
Yeah, Betty Ann, we need to make the motion for Russ, for Director Duke.
Oh, that was, I thought we were live when we did that. So I'm sorry, I couldn't tell when we were live and not. So,
Yeah,
okay,
no
you want to restate that motion?
Yeah,
Are we?
yes, ma'am.
Okay.
So I'd like to make a recommendation to the board in regards to Director Duke's performance, which has been exemplary through this last year, receiving maximal ratings from direct reports and from Board of Health members, with an all-time record high performance on culture since 2009, and make the recommendation for a 4% salary increase, which is the same salary increase to exceptional performers within Central District Health, and a $2,000 bonus. That would be the motion.
This is Jane Young, I second it.
Okay, thank you. We'll take a vote on that if there's no further discussion. Starting with Ada County, Dr. Young.
Jane Young, aye.
Raul Labrador.
Aye.
Dr. Epperly.
Ted Epperly, aye.
Boise County, Commissioner Stern.
Commissioner Sturm, aye.
Elmore County is absent. Valley County, Commissioner Hasbrook.
Mr. Hasbrook, aye.
Okay, thank you. That motion passes, folks, and sorry for the confusion. I couldn't tell if we were live or not. Okay, this brings us to the conclusion of our agenda for today's meeting. Our next meeting will be, of course, May 21st, as Russ has several times mentioned, at 8:30 in the morning. And I do thank everybody for their participation today, and particularly the public who was listening in. So at this time, I will call for a motion to adjourn.
Madam Chair, this is Commissioner Sturm. I motion to adjourn the meeting.
Thank you.
I'll-
A second.
I'll second. This is Jane.
I'll go ahead and take a motion, vote for adjournment, starting by Ada County. Dr. Young.
Jane Young, aye.
Raul Labrador.
Aye.
Dr. Epperly.
Ted Epperly, aye.
Boise County, Commissioner Sturm.
Commissioner Sturm, aye.
Elmore County is absent. Valley County, Commissioner Hasbrook.
Commissioner Hasbrook, aye.
Okay, thank you, folks. The motion for adjournment has passed, so have a great month, and we will be talking to you on the 21st of May at 8:30. Thank you.
Thank you.
Thank you.
Take care. Stay safe, everyone.
Likewise.
Be well.
Bye.